demonstrating it in one of the meeting from Saudi Arabia. Dr. Sajjad Rahman is doing this conference. But anyway, if you all want, we can update about PD. There's a lot of controversies, myth, treatment, and all those stuff. So except PDA, acyanotic heart disease, we are going to do. So I have nothing to disclose. So heart disease we all know there are two kind of a disease, cyanotic and acyanotic. Cyanotic means if kid is become cyanotic, and the acyanotic, obviously there is no cyanosis. And these are the typical two type of the disease congenitally we saw in our babies. So the congenital heart disease itself, the definition is defined as the structural, functional, or positional defect of the heart in isolation or in combination present at birth, but may manifest at any time after birth or may manifest at all. So there are a few congenital heart disease like TOF, tetralogy of Fallot. It can present at birth or it can present late in the life. Similarly, there are few congenital heart disease which present in the adult life. So it can present at any time, depend on the severity of the disease. The incidence overall congenital heart disease, cyanotic and acyanotic, is about 6 to 8 per 1,000 live birth, 1 per 1,000 at 10 years of age. 2% of total death is due to CHD. Acyanotic heart disease disorder are more common than cyanotic one. For girls, PDA, ASD; for boys, pulmonary stenosis, aortic stenosis, transposition, and coarctation are more common. But when we go to individually to each acyanotic heart disease, we will go to the incidence. This is the easiest classification for as a neonatologist for us, other than the, by the way, I will not show you any echoes because I think this is not the point that we know how to read the echo, but this is a different talk. But I'm going to talk purely about what clinically as a neonatologist should do or as a pediatrician. So this is a very simple classification. We made it. It's two types of CID. So acyanotic heart diseases, you have to see the pulmonary blood flow. If it is normal or decreased pulmonary blood flow, this is pulmonary stenosis, aortic stenosis, coarctation. If it is increased pulmonary blood flow, ASD, VSD, patent ductus arteriosus. So you don't have to remember, it's very obvious by the disease. So decreased pulmonary blood flow or normal or decreased where there is a constriction, stenosis, coarctation. Increase when there is a defect. Patent ductus arteriosus is a defect, VSD and ASD, all are defect. Similarly, cyanotic heart disease, which is another talk given by some of our speakers, is decreased pulmonary blood flow, normal pulmonary blood flow, and increased pulmonary blood flow. I think we will discuss in another talk. So to remember, and for our junior colleagues, this is very simple way. Cyanotic, check pulmonary plethora, pulmonary oligemia. Acyanotic, check pulmonary plethora, normal lung vascularity. All are very easy to know by this. So if it is more, then it's a defect. If it is normal lung vascularity, then it is, or oligemia, then it is some constriction or the restriction. Now, this is very important for our colleagues to know. Again, it is simplified. You have a blue baby, you have a pink baby. Check for femoral pulses. If yes, check for murmur. If yes, it can be the cyanotic heart disease. If no, it can be the cyanotic heart disease. If femoral pulses are not present, then it can be coarctation. But why it is important, this diagram, because if it is in the gray, then you should think of start prostate right away. Okay, so you don't have to wait for cardiologists. You don't have to wait. Develop your clinical skills. You can start the life-saving drug, which is the prostatin at this point. If a femoral pulse, if the baby is pink, femoral pulses are present, if there is a murmur, then VSD, ASD, and then you shouldn't start the prostatin. So this is very important way to look into it. So the acyanotic disease is a congenital defect in which the infant has no cyanosis because there is no mixing of unoxygenated blood in systemic circulation. And it is a circulatory problem that is congenital, and it is atypical of most congenital heart disease. But to explore or to tell more about this, this is very important statement that blood shunt from the left side of the heart to the right, causing over circulation maybe, and patient typically present with symptom of congestive heart failure, such as sympathetic stimulation, renin-angiotensin aldosterone mechanism alteration, decreased cardiac output. An example, we already discussed all those acyanotic heart disease. I just put these two tables that many of our fellows, many of our junior colleagues, and many of our postgraduate students giving exam. So the incidence of most common cardiac disease, these are all the cardiac disease present. This is an old study, but it is the same throughout the time, and it is per 10,000 in the Baltimore, Washington study and the Atlanta study. The other thing is which congenital anomalies has which side effect or which cardiac defect. It is very important. Many MCQs, they ask about these things. So these are the syndromes or disease which or associations, and these are the cardiac diseases, and these are the distinguished features on that. And it is very important to know because they are asking about many times these type of questions. This is another important table, and this is from the old book, but it is still valid. It is the radiographic diagnosis of cardiovascular disease in the neonates. This is the pulmonary vascular marking. This is the pulmonary vascular marking, increase or decrease or normal. If it is cyanosis, right ventricular hypertrophy, left ventricular hypertrophy, or compound cardiac hypertrophy, then this is the same. So this is the CTD, which is the cardiac transverse diameter on radiograph. MPA is the main pulmonary artery, and AO is the aorta. And you can see if it is like this, it's a normal. If it is this, is decreased. If it is up, it is increased. So that's how you also can figure it out. I'm not saying to be 100% sure about the diagnosis, but you have to do the echo. But the thing is that this gives you some ideas that what is happening in the radiograph in different congenital heart diseases. Now come to the cardiac evaluation. Sorry about that. Cardiac evaluation in infant and children. So feature associated with cardiac disease, feature associated with innocent murmur, and criteria for referral. So for example, in the history, parent or sibling with CHD, abnormal prerenal ultrasound, underlying genetic disease, age less than 1 year, symptoms suggestive of heart disease, and all those. If a feature associated with innocent murmur, like negative family history, normal prenatal ultrasound, non-syndromic, age more than 2 years, asymptomatic, and all those. But when you have to refer, when it is abnormal fetal echo, underlying genetic disorder, symptoms suggestive of heart disease, it is on the features in the history. Then come to the physical examination, all the same heading. Let's see the murmur. I will show you some movies of the murmur or the sound, how it looks like. If it is intensity, 1, 2, 3, 4, 5, 6. The one is the the quiet murmur, and the 6 is the loudest murmur. Without a stethoscope, you can do it. So grade 3 intensity, grade 2 intensity, hollow systolic, short systolic, harsh or blowing, increased intensity, diastolic. Diastolic murmur is always pathological. Remember this, diastolic murmur is always pathological. So if you have a murmur with a higher intensity, a hollow systolic and diastolic murmur, harsh or blowing quality, then it means is a criteria fit for the referral. Other heart sounds, S2, gallop rhythm, systolic click, friction rip, quiet precordium. If a normal S2 with normal physiological splitting, that's fine. No gallop, click, or rub, then it is innocent. If it is gallop rhythm, S3, systolic click, or the friction rub, then it is a criteria for referral. Other findings like abnormal vital signs, abnormal pulses, hepatomegaly, extracardiac congenital anomalies, more than 10 mmHg SVP gradient between the right arm and the leg. So is a criteria fit for the referral. Abnormal pulses, of course, is a criteria for the referral. So these things give you the snapshots that when you have to worry and when you don't have to worry, when you have to and it is all clinical. It's not that you cannot do that. Yes, of course, you cannot. You can do it very, very easily just to develop and examine the kids as much as possible. So the incidence of the cyanotic heart disease, if you divided it into the different ones, the female-male ratio is 3:1, VSD is 25%, the highest, then PDA, then PS, pulmonary stenosis, then AS, aortic stenosis, then coarctation of aorta, and the ASD is also the second number, same as pulmonary stenosis. So acyanotic 60 to 65 of total CHD and 30 to 35% is the cyanotic heart disease. Causes we already showed, we already discussed on all those in the table, but just it can be fetal and maternal infection or maternal diseases like German measles, cytomegalovirus infection, torch infection, hereditary consanguineous marriages, maternal age greater than 40, alcohol intake by mother, irradiation, maternal insulin dependent diabetes, all this can give the congenital heart disease. Fetal causes are fetal hypoxia, birth asphyxia, genetic disorders like Down syndrome, Turner syndrome, trisomy 13, Noonan syndrome, Williams syndrome. It's all on those tables. You can just go through those tables in details. We know why it's no cyanosis, because there is no communication between pulmonary and systemic circulation. So come with the type of the acyanotic disease with the according to the pulmonary blood flow is normal or decreased pulmonary flow. So we will go one by one. So start with the pulmonary stenosis, which is the obstructive lesion that interfere with the blood flow from the right ventricle. So what will happening here? That this is the aorta. This is the right ventricle, this is the left ventricle, this is the aorta coming out, this is the pulmonary veins, this is the pulmonary artery. So if something happened here, okay, then it is the pulmonary stenosis. Okay, this figure is for the aortic stenosis, but I am just using the same figure. So this is the pulmonary stenosis. Remember, the pulmonary and the aortic wall are the tricuspid wall, or they have the three cusp. So the pulmonary stenosis is the narrowing of at the entrance of the pulmonary artery, and the pulmonary arteria is the extreme form of the pulmonary stenosis. Now there is two types of the pulmonary stenosis: valvular stenosis and infundibular stenosis. Valvular stenosis are common, 90% of the cases, which is affected the valve. Okay, cups of the pulmonary valves are fused. It's like a dome shape, like a stenotic valve, and the right ventricular hypertrophy caused by that. Infundibular is the stenosis, is the less common, and pulmonary valve is normal, but outflow of the right ventricle is narrow. I will show you in a figure. So here, if there is a stenosis here and there's the constriction here, then it is the valvular stenosis. Okay, if up there or here, okay, basically at the entrance before the pulmonary valve, if there is a constriction, this is infundibular, because this is called the infundibular. This is the connecting portion from pulmonary valve to the right ventricular. If there is a stenosis there due to some reason, that is called infundibular stenosis. Now, pathophysiology and hemodynamics, we will go like in this form. It's easy. Whatever the cause may be, then pulmonary valve is obstructed by the fusion of the cups, resistance increased pressure in the right ventricular. Due to increased pressure in the right ventricular, increased pulmonary stenosis more. So this will cause the increase in the pulmonary vascular resistance, and then you can have a problem with your oxygenation. Clinical manifestation, no cyanosis, and sometime if it is mild, it is most of the time may be asymptomatic. But let's say if it is having some effect with the mild pulmonary stenosis, if the baby have or the child have exertional fatigue can happen. So what the baby can do to have exertional fatigue? The feeding, the movement. Okay, so this, if we have we have one baby which is diagnosis is a severe pulmonary stenosis, and it needs a cardiac catheterization, but we are waiting to reach the 2.5 kilograms. So the exertional fatigue can happen. We do in a bigger kid, they can have chest pain with exercise, and of course we have to have a systolic murmur. In severe is a dyspnea, cardiac failure, cyanosis, and a bigger kid like tetralogy of Fallot, child may scot to relieve the dyspnea. So let's see if this can work. So these are the sound of the murmur you can hear. You heard? Anybody can tell me you can hear this? Faraz?
Yes, sir. I can appreciate the murmur.
Okay, so look at this. It's like a drum beating sound. You see so this type of murmur, you have to take care of it, okay? Sorry, okay. So this is the systolic murmur. This is like a drum beating, and it is very obvious murmur that the pulmonary stenosis have. Investigation, of course, ECG you can do, echo you have to do, radiograph we do, and it shows the enlargement of the heart. There is no typical sign of that. Other than that, I give you the table, you go through that table, that what is happening in that in the radiographically. So what is the management? Medical management, if the child is in the congestive cardiac failure or the congestive heart failure, you have to start the diuretics, you have to start the captopril. If the child is big, then the chances of bacterial endocarditis is there, so you have to give the prophylaxis antibiotic for that. But most of the time is the surgical management, as I told you in our baby, because it is going into the congestive cardiac failure, and the right ventricular pressure is very high, and then later lead to the cyanosis. So the name of the surgery is the pulmonary valvotomy or balloon angioplasty or catheterization, as you can see here. So this baby will get the cardiac catheterization, and they will go through it. It is a typical severe pulmonary stenosis, is the valvular stenosis in our case. So they will go through, sorry about that, from there, and then try to balloon it up. Okay, so the bacterial endocarditis, primary tuberculosis, and anoxic spells and the congestive cardiac failure are the complication of that. Mortality is about 2 to 3%, good for the children with mild, severe pulmonary stenosis and cyanosis, and congestive heart failure has a little bit compromised mortality. I think Dr. Sajjad is asking, there's a session on PDA next month jointly by Dr. Okay, so he's answering my question. So thank you, Dr. Sajjad. Okay. So this is all about the pulmonary stenosis. And now we move to the next congenital heart, acyanotic heart disease is the aortic stenosis. So aortic stenosis is if you have a problem in the aortic wall. So this is the left ventricle, this is the aortic arch, aorta is, this is the ascending aorta. And if you have a narrowed aortic wall, then this has the problem with the aortic wall. So aortic stenosis is a narrowing or a stricture of the aortic wall causing resistance to blood flow in LV, decreased cardiac output, left ventricular hypertrophy, and pulmonary vascular congestion. Male is more than females. 80% of the CHD is atrial aortic stenosis. There are three types of stenosis: valvular, subvalvular, and supravalvular. The valvular is the most common. When the valve is affected, it is a bicuspid rather than tricuspid valve or the fusion of the cups. Subvalvular stenosis is the below the valve. I will show you in a diagram, and supravalvular stenosis is above the valve. So as you can see here, if it is here problem, then it is a valvular stenosis, narrowing of the aortic wall. If it is in the entry somewhere here, is this, or it's in the supravalvular, here is the constriction, then it is a supravalvular stenosis. And if it is here, then it is a subvalvular stenosis. But mostly the aortic stenosis is the stenosis of the valve itself. So here you can see here, this is the subvalvular stenosis here as compared to the valvular stenosis itself. So same thing, it happened congenitally, narrowing of the aortic wall, resistant to the blood outflow, which give extra workload in the left ventricle. Left ventricle is hypertrophied and blood backs up into the left atrium, and which increase the pulmonary veins, pulmonary venous congestion, and pulmonary edema due to the aortic stenosis. So this is the how the pathophysiology, and this is the hemodynamics change in this baby. Clinical manifestations is the hypotension, decreased cardiac output, tachycardia, poor feeding, same thing, fatigue and exercise intolerance if the child is big enough to walk and to play around. Dizziness can happen if the child is big. Murmur, of course, bacterial endocarditis, coronary insufficiency, or ventricular dysfunction can happen. So let's listen the murmur of this one. So as you can see here, see this portion and then the sound, and then again this portion with the very varying intensity, and then the sound, and this again this portion. So if you, I know it's it is difficult to appreciate on that side, but if you have this in your mind, then you can appreciate it. That's why we have to, hear the normal heart sound as much as possible to appreciate these sounds. Investigations: the chest X-ray, no cardiomegaly, aortic knuckle can be so prominent. ECG may be the normal EKG. Echo, you have to find out the changes. What I said, the left ventricular hypertrophy, the left atrium can be the enlarged, and angiocardiography also show the enlargement of the left ventricles. I showed you this thing. Okay. Cardiac cath also demonstrate the pressure difference between the left ventricle and the aorta. And these are the severity. Mild, if it is gradient, is a gradient means it's a difference between the two. The left ventricle and the aorta is less than 40, is mild. Moderate is 40 to 75, and severe is more than 75 mmHg. So these are the three severity at cardiac catheterization. Medical management again is the same treatment of congestive cardiac failure if it is happening. Prophylaxis for bacterial endocarditis in a bigger babies. Surgical treatment is the aortic valvulotomy, 10 to 20%, and 25% of the patient require additional surgery. Subvalvular aortic stenosis is the incision or the cutting of the fibromuscular ring, because this is just below the valve, so you don't have to touch the valve. And there are two procedures, Kono procedures, the Ross procedure. I just put it for your information, just for your extra knowledge. Otherwise, it's okay. If a non-surgical is the dilating narrowed valve by balloon angioplasty. So most of the time nowadays, we called it a non-surgical. By the way, we are doing this if it is a valvular stenosis. If it is subvalvular or the supravalvular, then it's difficult to do that. But if it is like a valvular stenosis, the dilating of the narrowed valve by the balloon angioplasty, again, which I showed you initially in the pulmonary stenosis, by the cardiac catheterization is the treatment of choice in those patients. There are complications. It can be the sudden death, endocardial fibroelastosis can happen, associated malformation like ASD, VSD, PS, or COA, coarctation of aorta. Prognosis is fair in cases of severe stenosis and those with other anomalies. The ultimate outlook is not bright due to the sudden death. So prognosis of severe aortic stenosis is not that great as compared to the other ASD or VSD or other acyanotic disease. So you have to be very careful if you have a patient with aortic stenosis. Come to the third one, which is in the same group, which is the coarctation of the aorta. So we are in the group of pulmonary blood flow is low or normal. So the coarctation of the aorta is a localized malformation. It is can be presented like a stricture like this, and most of the time it is postductal, or it is a structure of the arch of the aorta like this. So there is the two presentation. Anatomically, you can appreciate this. Incidence about 5% of CHD, 1/3 of it present after the childhood. Male is more than female, is 2:1. On the basis of their anatomical presentation, it's a infantile, which is the preductal type, is a 98% is more common. It's located at the region of the aortic isthmus. Postductal is the construction at on distal to the ductus arteriosus. So mostly it is the preductal thing. So description: narrowing near the insertion of the ductus arteriosus, increased pressure to the proximal to the defect, head and upper extremities, decreased pressure to the distal part of the defect. That's why we don't have the femoral pulses in these babies. What will happen that it happens due to some congenital causes, the narrowing within the aorta. It decreased the pressure to the distal part of the defect, increased the pressure to the proximal part of the defect, increased left ventricular workload, the flow of the blood to the trunk and extremities is going through the collateral arteries. Collateral arteries bypass the coarctation. Okay. And then this is one sign called Sussman sign. Dilatation of the collateral arteries are often seen over the scapular region of the back. And this is happening in these things. Hemodynamically, preductal type, the lower half of the body is supplied by the right ventricle through the ductus arteriosus. Postductal, right ventricle cannot maintain the blood flow to the descending aorta. So you have to imagine this anatomy, that where is the location of the coarctation and what happened. The pathognomonic sign is the absence of the femoral pulses. So the high blood pressure, bounding pulses in arms, weak or absence femoral pulses, cool lower extremities, sign of the congestive heart failure. If the kid is big, then it is dizziness, fainting. Cerebrovascular accident can happen. Muscle cramp in the leg while exercise due to the anoxia of those lower extremities can happen. X-rays show the dock sign. Actually, I don't know what is the dock sign, but there is something called dock sign. I will find it out what is the dock sign, but I don't know myself. Maybe some cardiologist can or radiographic can tell about. Retrograde aortography, it passes via the brachial artery, metamorphosis the presence of extent of coarctated area. Angiography, it shows the coarctation of aorta, of course. Echocardiography is the easiest way. It shows the other anomalies also. And the E sign as the barium swallowing. So this is the figure of the three like this. If you can see here, this is, you cannot appreciate in this X-ray because it is too much, but it's not the typical. But here, if you can see, is the reverse 3 like this figure of 3 in chest X-ray, or reverse 3, or the E sign, you can appreciate because of the knuckle of the aorta. So this is, and the rib notching is the pathognomonic. If you can see, the rib notching is you can appreciate. Okay, so this is the typical of the coarctation of the aorta, and of course the femoral pulses. Management. So if you find it out, then it's better. And of course, you have to start the prostaglandin treatment of the hypertension, like beta blockers, captopril we are using, rarely using methyl dopa nowadays. Surgical management is end-to-end anastomosis, which has to be done, grafting maybe, or cutaneous balloon angioplasty. Prognosis mortality is less than 5%. Preductal is poor, postductal is better. Increased risk in infant with other complex cardiac defects, which is because of the complex congenital heart disease. So the definite management is the surgical management for the coarctation of the aorta. Now move to the other group where you have increased pulmonary blood flow or plethoric pulmonary area in the X-rays. So these are, the first one is the ASD or atrial septal defect, which is the most common one after the VSD. So ASD is a defect in the septum between the atrium, as you can see here. It's very easy to see in the echo also. Females is more than male, is 3:1. Occur 10% of the total congenital heart diseases. So this is the normal heart, but if you have this defect here is the ASD, but it has a different types. I will show you in a minute. So this is the types of the atrial septal defect. Ostium primum, opening at the lower end of the septum, may be associated with mitral valve abnormalities. Sometimes it accounts about 20%. Ostium secundum, which is the most common one, opening near the center of the septum, at about 70%. And sinus venous defect is opening near the junction of superior vena cava and the right atrium, may be associated with partial anomalous pulmonary venous connection. It accounts about 5 to 10%. So the most common one is the ostium secundum. So these are the positions in a diagrammatic way, if you can see. So this is the superior vena cava is coming, this is the inferior vena cava, this is the right ventricles, and this is the pulmonary artery. So as you can see, this is the sinus venosus. This is the most common one, is the secundum ASD, and then the primum ASD, and this is the inferior vena cava or sinus venosus ASD. Coronary sinus ASD is very, very rare. So a patent, now, if you ask about the anatomy, you heard the term of patent foramen ovale. Patent foramen ovale is not an ASD. Okay, it is a normal remnant, or which remained patent for the months, and afterward it covered with the flap valve, as I wrote it here. If for any reason it can open to allow the shunt from right to left atrium, then it is called, or it is persistent, then it is called ASD. So the patent foramen ovale is the normal at birth, and it is not considered the ASD. Again, the location type we already know, we just show you in the diagram. Now, don't confuse with the ostium primum and ostium secundum. It's very easy to understand. This is the septum primum, okay? And if you have a defect here, is the ostium primum. Ostium is opening, ostium primum. This is the ostium secundum, if it is here, and this is the septum primum. If it has secondum septum, which is this one, then it's a foramen ovale, which is the normal. But if it is continue to have it and it's aneurysm, then it is abnormal. So if you see this diagrammatic representation, then you know what is the difference between primum, secondum, and the septum and ostium secundum. So again, if patent foramen ovale is failed to close, then what happened? Blood is shunted from the left ventricle to the right ventricle, because the left ventricle, the left atrium to right atrium, increased burden on the right side of the heart, increased pulmonary blood flow. Again, the same story. If it is, sorry, my mistyping is LA to RA. If it is pulmonary stenosis, then increased pressure in right ventricular, and then it can cause the Eisenmenger complex. Clinical manifestation is many. Mostly it happen if it is continue, it's not closed by itself in the later life. For example, the pectus cavetism, Marfan syndrome have this ASD, dilatation of the aorta, arachnodactyl, which is the cylinder fingers, and there's a lot of gaps between the finger, murmur, atrial dysrhythmias, diastolic murmur at the apex if it is not closed at the later age, and then it is pathological with or without mitral stenosis, and the ostium primum has systolic murmur, which is loud, harsh, and long. So let's see the loud, I mean, very loud, harsh, and strong murmur. So if you notice that this is a very sharp murmur, very sharp and very coming, right after the heart sounds, and it is very, very typical of this ASD. So what investigation you should do? You should do the electrocardiogram, echocardiogram. If you have the cardiac facility, they can do the cardiac catheterization, angiography, and X-ray. X-ray shows the heart enlargement. This is the PA enlargement, because as you know, in the X-ray, this is all the pulmonary artery and the left atrium. This is all enlarged. So you can easily appreciate that. Management, if it is not closed by itself, then it is nothing but the surgical management. If ASD1 require ASD2, and there's a different thing, they put a patch here to close the thing, like this patch between the two atrium. Prognosis is very low, operative mortality, so this is a very easy operation, and this is less than 1%. But there is a complication, because there is a pulmonary hypertension can happen, congenital mitral valvulitis can happen, that due to the pulmonary infection, repeated pulmonary infection, if I correct myself, and cardiac decompensations can happen. The other one thing, which is the most common acyanotic congenital heart disease, is the ventricular septal defect. And this is the most common. This is frequently occur with the cyanotic type, coarctation, ASD, fallows, pulmonary stenosis can happen. It is simple between the defect between the hair, as you can appreciate in this diagram, from left ventricle to the left ventricle to the right ventricle. Incidence about 20 to 25% of all cardiac lesion, more common in premature babies. Male to female ratio is equal. VSD is more common in other syndromes like Edward, Downs, Septal, and all syndromes can have VSD. Now the types of the VSD is two types, perimembranous and the muscular. Perimembranous is the more common, 70 to 80% of all the VSD. Defect in the membranous septum is called as high or membrane VSD. The muscular VSD is in the septum, is in the lower part, and it is about 10% of the total VSD. So this is the normal heart, and this is the VSD. This is the membranous VSD. And this is the muscular VSD. As you can see, this is the mixing of the blood from the left and the right oxygenated to unoxygenated blood. There are other classification they are doing it there, and it's called the not the infant inlet or inflow VSD. It's called the canal VSD because it may form a part of atrioventricular canal. As you know, the atrioventricular canal is the more common in the Down syndrome or the diabetic patient. Outlets or subpulmonary VSD also, but it is more in the East, Southeast Asian population. Japan is about 5 to 8%. According to the size of the VSD, it is classified into three: a small VSD where the defect is about less than 5 millimeter, and the moderate is about 5 to 10 millimeter. Large VSD is more than 10 millimeter. So these are the different form of the VSD, as you can see. And this is the AV canal, which is more common in the Down syndrome or the diabetic patient. So what happened if we have the VSD in our babies? Most of the VSD is closed by itself. That's a good. Or the by 1 year of the life. If left to right shunt can develop in the VSD. So congenital cause, abnormal opening, as you can see here. Pressure in the left ventricle is higher than the right ventricle. Blood shunted from the left to the right. And then, of course, increased blood flow to the lung, increased pulmonary vascular resistance, increase in the right ventricle, right ventricular, pressure, and the right ventricular hypertrophy, and then again the Eisenmenger syndrome. So this is the complication of this. If it is continue and it is not closed, then you have to close it by surgery. Hemodynamics is the same. If it is a small defect found in muscular portion, affects the slide, a small amount of oxygenated blood passes from left ventricle to right. Large defect, if it is found in the membranous portion, and it can cause the pulmonary hypertension, which is the more severe form, and the more amount of the oxygenated blood is passes from the right ventricle to the left ventricle. So the clinical manifestations are the same. This is called pansystolic murmur or the holosystolic murmur. So let's see if we can run this. So as you can see, it's a big chunk of the sound going on. So this is like a pansystolic or the holosystolic murmur, we call it. Breathlessness is if the kid is big, but of course, if he's in congestive heart failure in a small baby, also can have it. Difficulty in feeding. Most of the baby, if the VSD is affecting in the newborn, then there's a very difficult to feed them. Congestive cardiac failure, as I told you, tachypnea, slow physical development when they grow, and frequent pulmonary infection and cardiac enlargement. What you have to do, same thing, chest x-rays, electrocardiogram, echo is the diagnostic, and angiocardiography if you have a cardiac facility in use. The general management is the treatment of iron deficiency present, because if you have iron deficiency anemia, then the heart has to work too much. So this is very, this thing that many times we miss it. Infective endocarditis prophylaxis, like all other cardiac diseases, treat chest infection promptly, follow up these babies. Treatment of the congestive heart failure is the same, like diuretics or the captopril. And if it is if the baby reached to that stage, then you have to refer to the cardiac consultation for the treatment. Surgical treatment is the same. It has to be either the open heart or the cardiopulmonary bypass. Septal defects are patched up by the prosthetic Dacron or the direct sutures. They can do it, but this is the, of course, ultimate treatment. The other thing is they can do is the pulmonary artery bending, but the complete repair is the persisting approach or the netted Dacron patch over this thing. Prognosis, if it is a membranous defect, low mortality, less than 5%. If it's a muscular defect, then high mortality, more than 20%. The good and the bad, the most of the VSD defect is a spontaneous closure or reduction in size. The bad is this: it can develop into the congestive heart failure, recurrent pneumonia, acquired pulmonary stenosis, Eisenmenger syndrome, infective endocarditis, and growth failure. I will not discuss the patent ductus arteriosus, as Dr. Sajjad and Dr. Shadia is going to, and they will give you the whole lot of a thing on PDA in this same module in some other day. So I'll just quickly go through it now. All the acyanotic heart disease or cyanotic heart disease has a lot of nursing commitment. So these are the few I am just putting into it, so helping the family members, need for the comfort and the rest, nutrition needs, psychosocial need, continuing care, and the making of a family relationship. So ineffective breathing pattern related to decreased pulmonary blood flow, the nursing intervention, they have to check because they are more with the babies as compared to the doctors. The general condition, positioning, administer the humidified oxygen, assess oxygen saturation, provide calm and warm place, provide comfort bed. If it is decreased cardiac output, then they have to assess the cardiac function, provide appropriate play to reduce anxiety, monitor electrolyte level and all those stuff. Similarly, imbalanced nutrition status less than body requirements. So we have to be very careful in the nutritional status. Nursing should evaluate with us and see if it is vomiting, if the baby is inability to feed, check the weight daily and feed slowly or in the small amount of Q2 hourly feeds. Activity intolerance related to the imbalance between oxygen and supply demand. So the assess the response to the activity. Again, the maintain the neural. Actually, the whole idea of any cardiac baby is to provide as comfortable care as possible. So the temperature should be maintained, provide the calm and comfortable environment, which is very rare in any NICU. Okay, if you go, there are 100 alarms and these things are going on. So these are things which we have to consider on this. Change the position of the child. Every 2 hours is too much, but let's say 4 to 6 hours. Teach the parents about the child activity. Risk for infection, of course, we have to take care of as much as possible in these babies because they have reduced body defenses, that how to maintain a good hand hygiene, aseptic environment, maintain the disposal method of many diapers and everything. And we have to be very careful in these babies. And altered family process related to illness or the hospitalization, we have to assess the current knowledge because there are a lot of anxiety. Whenever you said that your baby has a heart disease, then it is too much anxiety among the parents. So we have to sit with the parents and to teach about those things. So the knowledge deficit, we have to try to fill the gap as much as possible, allow the mother to ask any doubt, explain the procedures, not this the surgical procedure, but the normal nursing procedures about medications, about nutrition, and explain because they have a lot of fear for the surgery. So explain the importance of surgery and follow up of the care.